Well, yes, and I am happy to introduce him. He is actually Dr. Thomas Wichmann. That's the correct way to say his name. And we're very happy to have you, Dr. Wichmann. Dr. Wichmann leads the Emory Udall Center of Excellence in Parkinson's disease research. And he treats and examines people who have movement disorders. Parkinson's is one of them that most people are familiar with. Dr. Wichmann is originally from Germany. He did his original medical training in Germany, and he came over here to the United States. He became a pharmacologist, as I understand it, and also did his residency and additional training, medical training at Johns Hopkins University in Baltimore. And he completed residency training in neurology here at Emory University, where we are grateful that he has remained. So at this point in time, I'd like to turn this part of the program over to Dr. Thomas Wichmann, who's going to talk to us about movement disorders. Now, I know that a lot of people are familiar with Parkinson's, but they may not be really aware of the whole spectrum of what we call movement disorders. So at this time, Dr. Wichmann, the floor is yours.
Yeah, hello. So I'm Tom Wichmann, as was correctly stated. I'm glad to be here. The discussion today will be mostly about Parkinson's disease, since there's so much new happening in this field of Parkinson's that I thought I'd really give you an overview, what it is, what sort of treatment options are available, what has actually changed over the last few decades. So that will be the topic to discuss today. Going right into it, and the slide. I thought I start with a bunch of take-home messages, so that you know from the get-go what we are actually going to deal with. So a few, maybe 10, 20 years ago, this was sort of the definition of Parkinson's disease. So it's a disease that is a movement disorder, so a bunch of disorders that we treat in the movement disorder clinic, where people experience not necessarily weakness, but they experience abnormal movements or changes in their movement patterns. So it's a movement disorder specifically due to a loss of nerve cells in a part of the brain that makes dopamine. So that was the definition, and many of you have probably heard what this definition before. So I'm going to tell you today that basically all parts of the sentence are wrong. One of them, Parkinson's disease, is really not a movement disorder. It's a movement disorder only in part. There's many non-motor features, and I will show you some of those. The statement about dopamine being so central is also being challenged. It's really involving many brain chemicals and other brain changes that are equally as important as the loss of dopamine. It is not necessarily due to loss of one specific brain region. Instead, it's shown to really spread throughout the brain. And that is what I'm going to show you in a few slides as well. And finally, is this really a brain disorder at all? No, it's not. It's actually a whole body disease, like many of the neurodegeneration conditions that we deal with. It's a whole body condition, it's a systemic disease. And therapies that we have, new and old, address the various chemical and functional deficits. So those are called symptomatic therapies, but we also have therapies that, or starting to have strategies at least, to prevent the neurodegeneration. So I will touch on that at the end of this talk. So what is Parkinson's disease? For those of you who don't really know what I'm talking about, Parkinson's disease is characteristically defined by its movement components. So this was described more than 200 years ago now, that people with this condition shake. They have a typical tremor at baseline, at rest, when they just sit there, essentially. They make fewer movements, they have slow movements, they have muscle stiffness, and also postural problems, so problems with their balance. That makes Parkinsonism, but then you can see that there are many, many other features that add to this. So there are There's a loss of the sense of smell. There is constipation. There's sleep disturbances, depression, and cognition impairments. All of this is not really movement related. These are non-motor features, as we say. Okay, so Parkinson's disease is much more than just the movements problems. How does this develop over time? This is an interesting slide showing the time from the diagnosis, that's here on the bottom, and the disease progression on the y-axis, as you can see here. So at time 0 here, that's the moment when we can identify Parkinson's disease as such. So we see movement problems that are so characteristic for this disease. That's when the diagnosis is made. But more than 2 decades prior to that diagnosis, something is already going on in the brain that we just are not able to identify as Parkinson's disease. And you can see a lot of these things listed here. So things like constipation, changes in your ability to smell stuff, sleep disorders, depression, cognition impairments, those things are all many years potentially prior to the diagnosis of Parkinson's disease. And once the movement problems have started here at time 0, these problems continue to be there and grow in intensity. But in addition, we find these movement problems that I just mentioned. So shaking, stiffness, slowness of movements, some balance problems, for instance. And then also in later stages of the disease, treatment complications that can also arise. So psychosis and hallucinations are part of this. Involuntary movements would be another. So those are all components of the disease, a very long drawn out process. Of course, right now we're treating basically the disease from time 0 to the end here, but it would be great if we have medications or other interventions that would come in much earlier than this to potentially prevent this moment of disease onset, of motor disease onset. Okay, so what are then early signs of Parkinson's disease? These would be the kind of telltale signs that you need to watch out for, and that would tell you whether to go to the doctor or not. And some of these are listed. I'm not really going into any detail here, but if you find yourself shaking, if your handwriting has changed, if you have a change in your sense of smell, if you have trouble sleeping, and any of these other problems developing, that is the time when you need to think about the possibility of having Parkinson's disease, and that at that moment you would have to really go checked out by a knowledgeable physician. Parkinsonism, so this combination of various movement problems, can also be caused by other diseases. So you can see them here listed. Other neurodegenerative disorders, so brain disorders where parts of the brain gradually dies, essentially, can cause this. Alzheimer's disease is one of the potential causes for a Parkinsonian movement pattern. Progressive supranuclear palsy is one of the other Parkinsonian conditions that we often deal with. It's the most common misdiagnosis, or missed diagnosis, I should say, in people with Parkinson's disease. Then it's important for people in the clinic to recognize that Parkinsonism can also be caused by drug treatments, so medications that you wouldn't expect to cause Parkinson's. For instance, neuroleptics, which are medications that are used to treat hallucinations, for instance. Metoclopramide and promethazine are used for nausea and vomiting. Anti-epileptic drugs are used for epilepsy, obviously. So those can also cause at least some features of Parkinsonism. Strokes can also lead to a Parkinsonian movement pattern, although they're of course not Parkinson's disease proper. So how do we diagnose this condition today? It's still the history and physical examination that we do in the clinic. That's the mainstay. This should be done by a movement disorder specialist, because they see a lot of these people with such conditions and can distinguish between true Parkinson's disease and others. So this is important. There are a couple of laboratory tests that we can use now. So there are some skin tests coming online for a specific protein called alpha-synuclein, which I will come back to. Brain imaging can be used. The DAT scan, the dopamine transporter scan, this is a scan that is actually abnormal in Parkinson's disease. So this can be used to diagnose at least a Parkinsonian condition. MRIs can also be used. They're usually meant to rule out other conditions, so strokes and such. And sometimes a medication trial is done. This used to be done all the time, like a decade or two ago. We have basically walked away from this because the other methods are just much more specific. So you get much better diagnosis if you use the other methods. So in the future, this is all going to change, I'm sure. And what will change is that we will rely a whole lot more on laboratory testing. So skin tests, blood tests will be used. So blood tests are currently being developed, and once that is available, it may be that your general practitioner is actually just doing this every year when you go to get your blood tests. When you get checked now for diabetes, in a few years, you may also get checked for things like Parkinson's disease or potentially Alzheimer's for that matter. Genetic testing will become more important. AI-assisted monitoring of movements and other activities will become important. So they may be able to just look at records from your smartphones or from Apple Watches, those kind of wearables. History and physical exam will not go away, so we still will do this, and that's still important, but perhaps not as important as it is currently. And brain imaging is also still there, and it still will involve these two modalities, MRIs and DAT scans, but there will be specialized scans that really specifically look for this condition. So this is currently under development. If you look at Parkinson's disease as a whole, the number of cases per year is about somewhere between 1% and 2% of the population has this condition. About 20 per 100,000 people have actually a new case of Parkinson's disease every year. You can see here on the right the age distribution of this. This goes from 0 to 100. Years. So before the age of 40, there are very few people with Parkinson's disease, but this really explodes after that. The average age of onset of the disease is in the mid-60s here. One other interesting thing about this plot is that it shows males and females separately. So males get the disease more commonly than females. So about 50% more males have it actually than females do. So this is an important statistic. It's completely unclear why this difference is between the two genders. Right, what's going on in the brain in Parkinson's disease? This is not going to be a long section, but at least I wanted to tell you a little bit about it. This is a brain slice, so a slice that you would see if you were to slice a brain in this frontal direction. And if you do that, one thing that will strike you, there's a lot of detail here to see, but one thing that may strike you is this dark stained stuff down here at the base of the brain. That particular area of the brain is called the substantia nigra. So this is literally the dark substance that's down here in the brain. And if you cut now the brain in the opposite direction, so now you cut it horizontally through this, it will look like this. This is the same thing, only cut in the other direction. And what you see here is this area, that is the substantia nigra. In healthy individuals, this is a really deeply stained, darkly stained part of the brain. In people with Parkinson's disease, that pigment, that stain is gone here. This was the first thing that people really have identified when they looked at brains of people with Parkinson's disease. This was more than 100 years ago now that this was identified. But this loss of this pigment, and they looked under the microscope at this area. And if you do that, you see something like this. So it looks sort of strange, perhaps a little bit. And what really strikes you first is this brown stuff here. That is, in fact, the pigment. So this is completely normal. This brown material here, this is in a nerve cell. So this here is a nerve cell. And inside of this nerve cell is this pigment that makes the substantia nigra dark. So that's fine. But what should not be there is this ball of stuff here within the cell. This is called the Lewy body. The Lewy body is named after the person who first discovered this, Frederick Lewy. And we now know that this Lewy body contains a specific protein in very high amounts. So this is an accumulation of proteins, which is called the alpha-synuclein. So this alpha-synuclein blood test that I mentioned earlier, or the skin test for alpha-synuclein, is looking for that very same protein that is also accumulating, pathologically accumulating in these nerve cells in the nigra. And it is thought that either that stuff, the alpha-synuclein accumulation, kills these cells, or at least it is somewhat close to the degenerative process. So it's an expression of the pathologic process that's going on. So those cells deep down in the brain that I just showed you, the substantia nigra, those are the cells that make dopamine in the brain. So this is a chemical that is coming from these cells, and that's then these cells send their long fibers to other parts of the brain where dopamine is actually then being released. So this chemical is really important. It's the level of how much dopamine you have in the brain regulates the amount and the speed of movements you make. So having a lot means you can move quite freely. Having very little of it means you have a hard time moving, or you may just not move at all. So in Parkinson's disease, this chemical is lost. So the dopamine cells are lost, the chemical is lost, and this very profound loss of dopamine leads then to the stiffness and slowness that you have in your brain. If you look at people's lifetime, they peak in the dopamine level in the striatum when they're in the mid-20s. Actually, that's when the level is the highest. So from then on out, it's sort of downhill as time goes on. So people, at some point, everybody would become Parkinsonian, maybe when they're 120 years old or so, when they have lost enough of the dopamine. Of course, most people don't reach that biblical age, so we die before we can become Parkinsonian. But this is really a very, very important change that occurs in the brain. And people with Parkinson's disease, that change, that loss of dopamine is just much faster than it usually is, right? And we have learned over the last decades that replacing dopamine can treat this Parkinsonian state. You can treat the movement problems of people effectively by just giving them back the dopamine that they have lost intrinsically. So about 20 years ago, there was a German pathologist who is quite famous, actually. It's Dr. Brack. And Dr. Brack did many things, but the one thing that he did in terms of Parkinsonism was that he started to look for these Lewy bodies that I had shown you earlier, not just in the substantia nigra down here in the brain, but throughout the rest of the brain as well. And what he identified was really that the substantia nigra was only one of many areas in the brain where this pathology occurred. It also seemed as if the greatest accumulation of Lewy bodies was actually not in the nigra, but was down here in the brain stem, in the lowest parts of the brain. And that he could kind of come up with a pattern of change, actually. So a lot was found here, a little bit less here, and then in the nigra, yet less, but still very present. And then throughout the cortex, or the rest of the brain, the upper parts of the brain here, the lowest concentrations, but they are clearly also involved. So this apparent spread of pathology was really interpreted in that way, that there was something that started on here, some process that started in the brainstem and then gradually spread up the brain to involve the rest of it, as if it was some sort of infection or infectious process that would spread through the brain. Nobody has ever claimed that Parkinson's disease is actually an infection, and it isn't really. There's no reason to believe that, but the spread inside of the brain behaves as if it was infective. So that was the pattern. In the meantime, the same pathology has also been identified outside of the brain, so in the spinal cord and in the gastrointestinal tract as well. So people have seen it on colonoscopy biopsies, for instance. So it's been not just in the brain, but also in other structures just as much. So the question is then, how does this actually hang together? Do these things actually hang together at all? Well, there has been, many people have thought about this, but one concrete idea is that Parkinson's disease may in fact not be a brain disease to start with, but it may start in the gut. It may be some sort of agent that enters your body, as is shown here in this figure, enters your body into the gut, is taken up by nerve cells, is transported to the spinal cord, and then gradually makes its way into the brain, starting again at the base of the brain here and then spreading. There's another way of entry of something, and I'll come to that something in a moment. And that could be through the nose. So you may inhale substances that really get into your brain pretty directly, actually, through what's called the olfactory tubercle. So this is the olfactory bulb, which is the part of the nose that generates the sense of smell. And from there, it would go into the brain and then involve also these structures that we just mentioned. And it may, in fact, in that case, end up in the gut, not primarily, but secondarily. So it may be first in the brain and then sort of slide down into or get down into the gut and other structures. So what are the things that could do this? So there are a few toxins or risk factors identified in our environment that may, in fact, be related to this. So these toxins some of these are listed here. So pesticides is probably first. We're all exposed to paraquat and other things in the environment that are very strongly toxic to us. But there are also these other industrial compounds, degreasing compounds or compounds that are used in dry cleaning, like PCE is a lot used in dry cleaning. Those things are all around us, and all of us are exposed to this stuff. And we may get it through our digestive system, or many of these are very easily vaporized, so you may in fact inhale them quite easily. So those are big worries that everybody is concerned about. So other risk factors are listed here. So we talked already about the chemical exposures. Of course, old age is a risk factor, as I mentioned earlier, because we all lose dopamine essentially. But head trauma and chronic inflammation are other things that have been linked to Parkinson's disease as environmental factors. Also some protective things. So if you're a chain smoker or drink a lot of coffee, your risk of Parkinson's is actually lower than it is in the average population. Doesn't mean that you have to now start doing these things, but it's just a finding which is of interest statistically. Genetic aspects to Parkinson's as well. So the single genes that can cause Parkinsonism, this is a minority of people. About 1 out of 5 have a single gene that you can then trace back to having caused their Parkinson's. But there are many more people whose genes may make them more susceptible to those environmental factors that I just mentioned. So this interplay between environment and genetic influences really is gaining a lot of interest in the field of Parkinson's. We can test for these things. So genetic tests is actually available right now. This doesn't really impact treatment a whole lot, so that's why it's not really done much routinely. This may change in the coming years. So some of the treatments that we have are known to be more or less less effective dependent on your genetic makeup. So it may become actually important to know what sort of gene makeup you have. So that is going to be something for the not very distant future, actually, to change in the treatment of Parkinson's. So what are the treatment things we do today for this condition? There is no known treatment that we can say for sure will slow the disease or stop it. So, but two things: exercise, what you did earlier with the video, and also some diet changes, specifically the Mediterranean diet, tend to be associated with a slower disease progression. So this is very good. Symptomatic therapy that we have is also very good. This really is a major activity in the clinic to treat people as good as possible with a very specific symptom. So it's highly individualized. Most of the time we use dopamine medications. I said earlier already that replacing dopamine through medications like levodopa is one of those drugs. Treats really the major movement problems of Parkinson's disease. The many other drugs we use in the movement disorder clinic to treat Parkinsonism, so cholinergic, norepinephrine systems, are all amenable to drug treatment, and we do this for a variety of reasons that I mentioned here. Very common low blood pressure issues or a tremor, of course. Other medications are also used often to treat side effects of the other drugs that are the primary drugs. Physical therapy and speech therapy are super important. So lots of people with balance problems need physical therapy. Speech therapy is often used for treatment of just low speech volume, but also swallowing problems in Parkinson's patients. And then we do surgery. So deep brain stimulation and focused ultrasound surgeries are the current activities that are done there. This is usually done for people who in some way are either don't respond to the medications or have so many side effects from them that they cannot tolerate them. So for them, these methods are very useful. There's a lot of stuff coming on board, new treatment strategies. Many of the new treatments are still dopamine-based or based on some of the other brain chemicals that we know are suffering in Parkinson's, so norepinephrine, acetylcholine drugs. There are new strategies to use this deep brain stimulation surgery. So new brain targets are being identified, and I realized that I didn't have time to really tell you in detail what this is. We may do this in the question and answer period, but new targets are being identified. There are also new ways of using this method, adjusting it to the level of Parkinsonism in a much more comprehensive way. And there are a bunch of neuroprotective strategies identified as well, so that can range from stopping really the formation of Lewy bodies to changing the cell death mechanisms that eventually kill cells in the brain. So those things can all be potentially changed through neuroprotective strategies. For any of this to work, we need to find out when the disease really starts in a given patient and how far it progresses, how quickly it progresses. This requires the use of biomarkers. So a biomarker is some sort of identifier that tells you how severe the disease is in a patient at a given time, preferably before they develop any motor signs. So we can see how quickly they progress and can measure whether a given medication actually helps them and reduces the disease burden. So that this is very nice diagram from a recent study where they simply looked at the pipeline of Parkinsonian of drugs that are being into development for Parkinson's. And this is a super active field. So there's so many trials ongoing. At the time when this was published last year, they had 136 trials underway, about half of them for symptomatic therapies, but the other half was really for disease modification therapy. So this is a constantly changing field, but also one where more and more drugs and other approaches are being done. So this is a very, very active area of research. So if you're concerned about suffering from Parkinson's disease, coming to the conclusion here, find a knowledgeable clinician that be looked over, make sure you you talk with them about your concern, get informed about the disease. So if you have the disease or if you think you might have it, read up about it, learn about it, or go to support meetings and other things, really engage with other people with Parkinson's disease in order to really get more knowledgeable and get a more active approach with the disease and become involved in advocacy activities if you like being involved in such activities. So there are many patient support organizations that really are there to help and to organize people in their efforts to fight this disease and participate in clinical trials if you can. So this is a little slide on a patient who we had in the clinic, John Humphreys, who was really known to have participated literally in dozens of different kinds of clinical trials. He got a lot of enjoyment out of this. And of course, we got a lot of data out of this. So this was really good on both sides. And he just very actively fought the disease and was able to deal with this in this way, much more so than if he just had stayed at home and waited for it sort of to take its toll. So this was a very is a very good way of dealing with the condition. So take-home message again summarized here. Parkinson's is a systemic disease, myriad movement and non-motor aspects. During the course of the disease, many types of cells in the brain and many chemicals are affected in a somewhat predictable manner. Remember that spread that I showed you. It's seen this alpha-synuclein molecule, this protein here is considered to be really an essential step in the development of Parkinson's disease. And the therapies I have shown you, they address the different chemical and functional deficits. I talked to you about lifestyle changes, so more exercise, different diet potentially. And then there are new medications and interventions coming online that might help really with the neurodegenerative process. So I think with that, I want to thank you all for listening. It's wonderful to have this opportunity to talk with you today, and I'm happy to take questions.
Thank you, Dr. Wichmann. I learned a lot. And one of the things I think that was most intriguing that you talked about, there are a couple of questions here, but I want to get one out first. The origin of Parkinson's disease, you said maybe it started as a gut problem that crossed over into the nervous system. And you also talked about inhalation, inhaling something. And then it's sort of like one of the symptoms you had, Parkinson, that's like something that was like an infection, like a change in smell is a symptom. And when you said that, I was like, that's like with COVID. COVID is an infection. It's a virus. And one of the symptoms was a change in smell. So I thought that was a really interesting correlation. Is the infectious disease model still something that is being investigated? And do we have any such studies here that you want our audience to get involved in? You didn't talk about your studies, but I did want to understand the viral infection type thing.
Yeah, so this is not a direct, I want to stress that there's no evidence that Parkinson's is an infectious disease, right? So this is clearly not. But this spread of this protein, and there's a lot of detail now known how this might happen in the brain, which I didn't get into, but the spread of this protein behaves like some some infection would spread in your brain. So it has some resemblance with that process. So it's a useful model of understanding how this spreads in your brain. So coming back to this, the COVID question, or in general, actually respiratory infections that such as influenza also, this is a super interesting topic actually, because these diseases may trigger chronic inflammatory states in the brain. We know that one of them did this in the early 20th century. There was a influenza outbreak that in its wake, decades later, led actually to many people having Parkinsonism as a consequence. And there's certainly enough worry about the same thing happening decades, or maybe not so many decades after having been exposed to COVID or having been exposed to H1N1, all of these more recent infections may in fact result in significant brain consequences that we're just seeing the very superficial layers of right now, but which may develop in the future. So it's a big concern.
Thank you. There is a question. I'm going to go to the Q&A first because there's only one here. It says, if a person has tremors but has not been diagnosed with Parkinson's, what other disease could this person have?
Yeah, good question. Thank you. Tremor is a very common symptom, and it is Parkinson's disease is actually not the most common cause to have tremor. So all of us shake sometimes. If you drink too much coffee, you will shake. Or if you're super nervous in front of an exam or something, this will definitely lead you to shaking. A disease state that often leads to shaking is called essential tremor. That's a pathologic state. Obviously, it's a genetic condition that many people have running in their families. It's the most common cause of tremor. And that disease usually is mostly just tremor. So there are few other things that are associated with it, but it does not come with all of the negative baggage that Parkinson's would come with, right? So there's no general slowness of movements, or usually not major cognition changes either. So essential tremor is the most common reason to have to shake. And the difference between that and Parkinsonian tremor is that essential tremor is one that occurs with movement. So when you move, let's say you write something or you reach for something, you shake while you're doing that activity. So that's an action. It's called an action tremor. That would be essential tremor. If you find yourself just sitting there and shaking, okay, you watch television or something and just shake, that is more likely to be Parkinsonian. But even that is not always Parkinson's disease, obviously, but it's a more common type. So a movement disorder person will easily tell you what sort of tremor is this actually that you're having. So that's the answer.
Okay, I'm going to the chat now. Thank you, Dr. Wichmann. That's a good answer. Let's see. Do we get tested for Parkinson's routinely, or should we request it? And you talked about something called a skin test.
Yeah, so this right now nobody gets routinely tested for Parkinson's, so this is not happening. But and there's also no reason to do this at this moment. Right now the disease is really diagnosed at the moment you have movement problems. So if you develop these movement problems, you should get tested. But before that, there is no really unique way or single way to actually tell you whether or not you are at high risk of developing Parkinson's. There's a mention about the skin test. So this is a test that has become is commercially available and is actually being offered. It's a good test, but it is often also resulting in false results or false positive tests, and you end up with a lot of anxiety because somebody had, for some reason, a positive outcome of this, and it is, in the individual case, extremely hard to really judge what the validity and importance of this test really was. I would say if you have a positive skin test in the absence of any motor dysfunction of any kind, you don't have Parkinson's at that moment, right? So this is only useful as a confirmatory test, perhaps, but not more than that.
Okay, there is a question up here from Shannon Fain. If you were exposed to chemicals and it led to Parkinson's, would that happen on short notice, or would it be longer, many years down the road? Because you had a graphic, and that may be what he's talking about or what they're referring to, but I think it's the environmental exposure that you alluded to with the pesticides and the pollution.
Yeah, that depends on dose, right? So if you were, your Agent Orange is a famous example for this. If you were exposed to Agent Orange during the Vietnam War, decades later, you may come down with Parkinsonian signs, and the VA is now recognizing that as a, or not now, for many years now, has recognized this as a reason for an occupational exposure to a toxin that caused Parkinson's. So this would be an exposure long time after. On the other hand, has been an example of a contaminant to illicit drugs that were used in the early 80s for a brief time. It's called MPTP. That is an extremely potent toxin that people had ingested or had injected into themselves, and that resulted in Parkinson's disease within a matter of a few days. So it really is a matter of, you know, what are you exposed to and what dose you are exposed to. But I would say for most of the things that were on my slide there, this is not something that you would be exposed to today and have Parkinson's tomorrow. This would really take years, if not decades, to develop.
Okay, and this looks like probably one of the last ones, and it's from Q&A. If a male has dementia and hand tremor, is this a sign of Parkinson's? So part of me wants to know who's evaluating the persons. So I'm going to leave that one with you, because you talked about men being more likely to have Parkinson's as opposed to women. Higher prevalence in men.
Yeah, so there are lots of aspects to this interesting. So one aspect I want to maybe emphasize is that these two diseases, Alzheimer's or dementia and Parkinson's disease, are always treated as two different entities. And we have actually in our neurology department, two different departments that are going to deal with these things, or divisions that deal with this. This is artificial. In people with Parkinson's disease, people with Parkinson's disease often develop dementia in the late stages of the disease. This is a frequent thing. So Parkinson's is a dementing condition, if you will. But if you look at the brain of people who have had this, about 50% of those, or a little over 50 even, of those who were examined in this way have actually both conditions. They have the pathologic evidence for Parkinson's, that may be the disease they were diagnosed with in life, but they also have amyloid and beta amyloid and tangles in their brain, which is a characteristic for Alzheimer's disease. So those two conditions can occur and often do occur in the same person, and it is extremely hard to say which of them cause actually the dementia in a given individual. It's sort of the two diseases seem to almost merge towards the end of the life. So.
Thank you. Last thing, Dr. Wichmann, several people have asked for your contact information. I mean, that's not uncommon for us. But I think that the idea of trying to make sure people get the right kind of evaluation for their tremors, who should they see, that kind of thing, is what they're really asking. And just help us with that one. And do you have some studies that you want them to know about? Do you have a page that we need to refer them to for movement disorders studies? You showed some dancing.
Yeah, most of the studies in the movement disorder section are currently done in the field of freezing of gait. So gait and balance problem are very high on the list of studies, and deep brain stimulation studies. So those two areas see the most studies for us, or in our group. The best person who would know about basically all ongoing studies, it could refer you also to the individual ones, is Dr. Stuart Factor, who's the head of our clinical trials program and actually also the program director. So he can do this best. I think you can also write to me if you would like to. I can do what I can to get you into those trials. I'm happy to answer emails. So if you want to send me emails, or maybe the leaders here could send the information about the the contact out to the audience as well. And of course, if you want to really be evaluated, the easiest is to just call us. So it's 404-778-3444 is the number.
778-3444. 3444, excuse me, 404-778-3444. If you think you need a Parkinson's evaluation,